Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find our previous episodes on Apple Podcast, Spotify, and on your favorite podcast app. We're wrapping up our coverage of Convergence 2023 with a session titled Year in Preview. That's right, it's not year in review, but year in preview, which highlights the latest abstracts presented at Convergence that are expected to make the biggest waves in the coming year. We've invited the two speakers from the session to discuss some of their favorite abstracts as they relate to rheumatoid arthritis and systemic lupus. We have a variety of abstracts to discuss, including artificial intelligence, steroid use, hydroxychloroquine dosing, preventing the development of RA and lupus, pregnancy in lupus, methotrexate dosing, and much more. Dr. Joan Bathon is a rheumatologist, professor of medicine, and chief of the Division of Rheumatology at Columbia University College of Physicians and Surgeons. Dr. Bathon's career has focused on understanding the pathogenesis and functional consequences of inflammation in rheumatoid arthritis. Dr. Jill Buyon is Sir Derek and Lady Valmont Professor of Rheumatology and Director of the Division of Rheumatology at New York University School of Medicine. She's also the Director of the NYU Lupus Center. She's a physician scientist specializing in translational research and management of systemic lupus, lupus nephritis, neonatal lupus, and rheumatic diseases in pregnancy. This episode was recorded live on the floor of the San Diego Conference Center. Enjoy the show. Joan and Jill, welcome to the show.
Thanks. Good to be here, John.
Likewise.
So you guys are doing Year in Preview, which is, I guess, supposed to predict what will happen in the next year based on some of the abstracts that we learned about during this year's Convergence. Joan, let's start with you. There's been a lot of talk about artificial intelligence at this year's Congress, including the keynote speaker, which was pretty remarkable. Can you tell us what AI is doing in terms of rheumatoid arthritis?
Well, one of the abstracts that was quite interesting this meeting was one in which Canadian investigators, Carol Hitchon et al., did a very complex analysis of machine learning to interpret hand x-rays in patients with rheumatoid arthritis. And they did two things. One is they wanted to be able to identify the joints, because you can't read the joints if you can't identify the joints. So they trained their machine on children's joints, interestingly, and then validated it on adult patients. And they found that the machine learning endpoint, which was to distinguish a joint from a non-joint, was really quite excellent.
Good.
But
step one.
That's step one. The more difficult one is for the machine to learn what's an erosion and what's joint space narrowing. And that was a little bit trickier and didn't do quite as well, but still performed quite nicely. They had a few different models, and they chose the one that had the best performance, the best accuracy, and the lowest standard deviations. But they had more trouble with the wrists. Wrists are more complicated, a lot of bones with overlapping features, so it didn't perform quite as well in the wrist. But that was really encouraging because the Sharp-Van der Heide score is something that we all want in our RA patients. But the truth is it's onerous because it's time intensive, it's tedious to do, and no one gets it clinically. So this machine learning would give us the opportunity to be able to get a sharp score on our patients through a machine. The trick is, will it be able to distinguish progression of erosions and joint space narrowing over time? And they didn't get to that point yet. They distinguished joints and the features at baseline, but not progression. Okay. So I think that's going to be the future.
Yeah, I agree. It's incredible. And the changes with AI are happening incredibly quickly, right? So by next year, they may be replacing our physical exams too. It'll be interesting to follow this going forward.
Yeah, I agree. It's very exciting. I mean, AI is changing so much every day. And you will see I have a cute little slide about that and how we chose the abstracts.
I love it.
And some
Jill,
of the,
yes.
yes, just one other comment.
Yeah.
Some of the goofy things that people are trying to do with it is to distinguish RA from OA from another inflammatory arthritis. We don't need AI for that. You can look at those films and distinguish that. But no one wants to do a sharp score that can take an hour of
tedious.
tedium.
Yeah, fantastic. Jill, tell me something about lupus and where you see things going. Let's talk first about steroids.
So that's a pretty broad mandate or ask. So basically, I think this year we continue to see the theme of less steroids is better, less steroids are better, because everyone understands the side effects. And one of the studies that I thought was interesting, Amit Saxena evaluated placebo arms of lupus nephritis trials. And I'll speak a little bit about that tomorrow. But it basically showed, in short, that although you would give initially intravenous steroids, that once you get past that, if using lower dose steroids and more rapidly tapering, it's not that it's a big difference with regard to efficacy. In fact, efficacy could be the same, but much better in terms of side effects. And that was followed by an abstract by Maria Delera, who basically looked back at a trial in lupus, which was called the ALMS trial, and looked at a current trial, Aurora, where it's voclosporin, and basically showed that if you add voclosporin and mycophenolate, you can get away with a lot lower steroids and still get very similar efficacy. So that's a big theme for lupus and for lupus nephritis. We're really moving away from that really high dose steroids make people cushingoid and people don't want to take their medications. And I think this is great news, especially for our younger patients.
That's fantastic. You know, we see that trend not only in lupus, but also in vasculitis and other rheumatic diseases.
And to tag on to that, if I may,
Of course.
there was an abstract for RA where they were looking at, we know that the higher the dose and the longer the treatment with steroids, the worse the cardiovascular and other bad outcomes. But what this abstract did is they also looked at the recency of the exposure. So if they got 5 milligrams or 15 milligrams or 20 milligrams, but it was a year ago versus current versus 90 days ago, was it still substantial? And they still saw a higher risk even a year later.
Wow.
Well, I may be wrong, but at least we were taught that for avascular necrosis, which obviously is a very big deal to have a hip replacement, that incurring that risk with steroids even many years ago for lupus nephritis, you might not be on steroids now, but you incurred that risk.
Wow.
And that's really disquieting.
Okay. Another thing that I think is interesting is the idea of trying to prevent rheumatoid arthritis from developing in the first place. Joan, have you noticed any interesting abstracts about that topic?
Yeah, there was one, the Epipra trial that was presented by Dr. Cope from the UK, and it wasn't overly exciting, but since there's so few of them, I think that it's worth mentioning. So they looked at patients who were ACPA or rheumatoid factor positive, either both positive or very high titer ACPA, and had some arthralgias, but no clinical synovitis. And they randomized them to abatacept or placebo for 52 weeks, took them off, and then they followed up at 104 weeks. And like one or two other trials that have taken a similar approach, they saw a delay in the evolution to classifiable RA. So they both met criteria for RA eventually, most of them, but it was slower to develop in the abatacept treated group. So it doesn't prevent it. It's really delaying it. And when you start something before people are overly symptomatic, you have to make sure that safety outweighs efficacy.
Right.
And that abatacept is relatively safe. So that was okay, but it does make you wonder, could you just pulse people for 6 months with a drug and then give them a year off? And then when they start getting symptomatic again, maybe pulse them again as opposed to continuous lifelong therapy. Maybe you could just keep postponing it.
Keep kicking the can down the road.
Yeah.
Because I know there's been other trials like hydroxychloroquine, for instance, that was a negative trial.
So the further you go back in the chain, the farther you are away from the clinical disease, the less successful these treatments are. So Kevin's wasn't successful at all. And he had to choose a drug that was safe because, again, you might be treating somebody for years and years. And then there was a trial with methotrexate that didn't work either. One with rituximab, one dose that did delay onset.
So I guess that was similar to the abatacept.
It was
is that
kind of
it
similar.
kicks the can down the road, but it doesn't really help to prevent it from
Exactly.
happening.
That's really the couple that have shown. There was another one by Paul Emery in 2009 using abatacept also, but they were even closer to the endpoint. So they had clinical arthritis, but they didn't meet criteria. And abatacept delayed it a little bit. But that's the best we can have done so far.
If I had to foreshadow for next year's ACR meeting, let me say that you'll be soon seeing the results of what's called the SMILE trial by Olson and Karp, where they are looking at patients who have less than 4 criteria for lupus and randomizing to hydroxychloroquine or not, and then seeing whether or not a 4th criteria or when you go from 2 to 3. So it'll be very analogous to the Kevin Dean. But of course, one of the shortcomings at the end, so that we're not totally leaning forward, is that the matching, because it was very hard to do this, between people who might be more likely, for example, have DNA versus those that might have, alopecia and joint. So it gets tricky with a really heterogeneous disease. But the theme that we can move along the spectrum is really exciting, and it's everywhere.
Jill, how does that one differ from the Nancy Olson?
That is Nancy Olson,
Oh,
Olson and Karp. I said both. That's why
you said Olson.
Yeah, Olson and Karp.
Interesting. I wonder if we need something even bigger, like could think about CAR T cells in preventing these things. Although certainly I think that the risk of those is much, much higher.
You have to go with something that is not overly expensive and something that is not going to carry the potential severity and risk of CAR T cells.
Yep.
Right.
Jill, tell me about pregnancy in lupus. What's
you mean
new?
My favorite topic?
Absolutely.
So this year has been pretty exciting, I think, on that front. We heard an abstract that really went over the potential of severe cardiovascular events in pregnant women. And everybody knows there's a big push in the country to try to understand the increasing maternal mortality. And this particular abstract looked at women who were pregnant who had autoimmune diseases, and it varied, even including like spondyloarthropathy and other diseases. But the idea here was to evaluate cardiovascular events during pregnancy and postpartum. And of course, my interest was piqued that if you really looked at the data closely, the groups which were in trouble, obviously those with antiphospholipid antibodies, but also lupus and lupus nephritis.
Wow.
And interestingly, the venous thrombosis after pregnancy, meaning in the postpartum period, which sometimes people don't realize is a very high place for increased cardio events and rather VTE events and clotting. So I thought that was very interesting to really wake us up to that and juxtaposed to actually the Royal College of Obstetrics and Gynecology has put forward very interesting guidelines for postpartum treatment with medication and Lovenox postpartum for 6 weeks. And actually SLE activity is equal to 3 points. And so I think it behooves us who take care of lupus patients to really nail down what we think about as lupus activity. But even if you've had preterm birth, which gives you 1 point, you happen to be a little heavy and you're over 35 years old, even that in a lupus patient or a non-lupus patient constitutes a recommendation for Lovenox. So
for
I think that's
Lovenox
interesting.
to prevent VTEs in the postpartum period.
Exactly.
That's really fascinating.
It is really interesting. So that was exciting. Then you get back to things like, we should make sure we replete vitamin D. That's interesting. And Michelle Petrie.
Tell me more about that.
Well, basically, she showed that depending on the level of vitamin D, if you're too low or actually too high, that might be associated with adverse pregnancy outcomes. A simple little thing, a poster, but a little pearl. Do we always remember to check vitamin D levels in our pregnant patients?
How high do you want them?
Well, so her values were like between 35 and like 45 or 50. So you don't want to be over that and you don't want to be less than 30. It's interesting to me because vitamin D is actually antifibrotic. And for some issues in pregnancy, which I'll get into in a moment, that could actually be important. But this is not to be egotistical in any way. But I thought this is a good year for us because we were evaluating anti-Ro and pregnancies. And there's been incredible controversy about how do you do fetal management for women who might be at risk for heart block, which is such a rare disease. So we presented at the meeting this year was that titer really matters. And that if you look at women, about a third of them probably have titers that are not really for having risk, and therefore you could really cut back on your recommendations about echocardiograms. So I think we showed that extremely nicely, and you could increase your risk from, you think it might be 1% or even less, all the way to 3 to 7%.
Depending on the titer.
Exactly,
So higher titers, higher risk.
Exactly. So your risk for heart block is clearly having a previous child with heart block and your titer. But titer doesn't mean everything. But the other part that was cool, I don't know, maybe Joan, you know about this, but we teach women to actually do their own Doppler home evaluation of the fetal hearts. And so women who had high titer actually were taught to do 3 times a day home fetal Doppler monitoring. We had, at the end, I mean, where we are now is about 261 patients have been past 26 weeks, and that's the time where usually you're going to get heart block by then. And we had 10 cases of block, every single one of them picked up by the Doppler, and 7 of them second-degree block, which has implications to reversal. And in no case did echo pick up an AV block when it hadn't been picked up by interval FHRM. So the only downside is that we had a pediatric cardiologist and actually a trained coordinator listening. And so the pediatric cardiologist listened. This was kind of like, you can send a text and then the text is listened to. And so what we're trying to develop now, speaking about AI, is trying to make a Doppler where like it's a red light, green light, yellow light. And this way the mother won't feel burdened like, oh my gosh, she has to make the decision. But because so we took the decision off the mother by having the pediatric cardiologist listen to every single text.
And it's based on heart rate?
Yes, heart rate. It's heart rate and rhythm.
In rhythm.
So, you know, it da-da-da-da, or is it da-da-da-da, or is it da-da-da, you know? Anyway.
Fantastic. Joan, tell me a little bit more about methotrexate. So what I use when patients get up to 20, 25 milligrams of methotrexate, I was trained that we should do split dosing. Have we learned anything more about split dosing in this year's Convergence?
Yeah, I think probably what people are taught nowadays is if they have intolerance at 25 milligrams or they're not responding well, that they should go to sub-Q. The split dose idea is a very old one that we actually, when, you know, I'm of the age that I was on the forefront of methotrexate use, and we used it in split dose because historically it was given IV first for psoriasis, and then it was switched to PO every day, but there was a lot of toxicity, and then it was switched to every 3 doses, 12 hours apart, Monday morning, Monday evening, Tuesday morning. That's how it was given. And then eventually we went into this once a week thing. But so it's, this particular abstract is revisiting the past. And their argument is that if you don't get enough absorption by PO, the option is to make it every 12 hours, 2 doses, and you'll get better absorption, better levels. And they didn't present measurements of those levels, but it seems reasonable that they should be higher. The unfortunate thing is I don't know why they chose the primary outcome that they chose. They chose the 24-week response split versus single dose, and they allowed people to add a second DMARD at 16 weeks. So by 24 weeks, there was no difference between the 2 groups because a substantial portion had had another DMARD added. But when they, as the secondary outcome, the 16 weeks were quite different. So the patients on split dose had significantly higher efficacies in all the ACR 20, 50, 70s and reduction in DAS28. There was about a 25% difference or so. But it wasn't their primary outcome. And toxicity was pretty similar, except the transaminitis was higher in the split dose. So, I mean, it's interesting because it's like deja vu all over again kind of thing. But it's another option for people to help patients embrace methotrexate, I think.
Love it. And methotrexate, the backbone of rheumatoid
that could be
arthritis.
applicable to lupus also. I mean, clearly, I'm very impressed with methotrexate in joints. I mean,
for lupus arthritis.
In fact, but the difference, I mean, in my own experience, you need way lower doses than an RA. And you either get it or you don't. I don't really see a great difference. Like when I give somebody 7, 12.5 to go up to 20, I rarely see any big difference.
And you already at
I mean, to me,
you see
that just may be my own anecdotal experience, but it works very well in some
They don't
patients.
have as much synovitis.
No, absolutely not.
It's more joint pain. Tell me about hydroxychloroquine.
Oh, this is the kid on the block. So for the last 5 to 10 years, the word on the street is adherence, adherence, adherence. And I guess it's a sad day when we have to actually draw bloods on our patients to know if they're really taking their medications. I actually find that a sad day. Nevertheless, I think for some of us, conversations with our patients may or may not replace actually doing levels to see if they're telling us the truth. But on the other hand, and we've certainly learned a lot about that, and because of this adherence and realizing that so many patients are not adherent, there have been levels, the ability of the physician to get levels of hydroxychloroquine. This is now commonplace. Commercial laboratories can absolutely get us back hydroxychloroquine levels. So you might want to think, gee, instead of talking about adherence, why don't we talk about efficacy? What's a therapeutic target? So I think this is where the field will shift from, is the patient telling you what they're doing versus what level should we use to balance against eye toxicity? And the problem with the eye toxicity is that when you really adhere very carefully to 5 milligrams per kg, especially early on in the disease, are you really getting what you need to get? And how do you balance that? So
meaning it's not as efficacious.
It may not be efficacious, because we used to, off the bat, I don't know about an RA, 400 milligrams, that's what we use, that's what it is, right?
Yep.
But then the ophthalmologist came along and said, hey guys, after 8 to 10 years, you got to watch out because retinal toxicity is not a joke. It's not just in the textbook.
Yeah.
So here, I mean, just to say, so now there was one of the abstracts that looked at therapeutic levels and tried to say, well, to achieve less disease activity, let's look at people with a certain degree of lupus activity, to say SLEDAI of 6, don't worry about that. But the idea of balancing activity against the dose of hydroxychloroquine to reach a certain level. And the bottom line was, not so unexpectedly, about 1,100 nanograms per ml, basically showed us that that was going to be the dose. And that if you were less than 700, then that's really not where you want to be. And if you're higher than 1,100, because I actually asked the question, it just doesn't seem to give you any more benefit if you balance this against how many people are at a certain level of disease activity. So, I mean, that's interesting. It's a guideline. The problem is that if you stop the drug for a few days, your level may change dramatically. So really, it's the tissue that matters. But this is where we are right now. And I think that's interesting.
Okay.
Is it hard to tease out the efficacy of hydroxychloroquine on top of all the other?
Well, I mean, obviously it's hard, but there are so many. If you look at your patients, the most patients in any cohort, pretty much they're on Plaquenil as their main drug. That's the greatest percentage. So I think it is hard. And obviously in patients who have more organ involvement, Plaquenil is not going to be enough. But I think this gives us at least a way to target and say, okay, of this drug, this is where we need to be, and you're not there. And I think it's helpful.
Fantastic. Now, thinking about the year ahead, let's say this is now Convergence 2024 and we are in DC.
Is that where we're going?
Yeah.
Okay.
What do you guys expect to be learning about or seeing? What abstracts do you think are going to be the big deal next year?
Oh boy. I think I've already told you it's going to be the SMILE trial.
The SMILE trial.
Because, I mean, we all know that it's pretty much ending. And by the time it comes around, I think we're going to see that.
I'm looking forward.
I'm going to predict that to be a
I'm looking
plenary.
forward to that. That's going to be exciting.
I could be wrong, but because regardless.
It's been going on for quite a while.
Right. And it doesn't matter whether it's positive or negative. It's of great interest and it should be highlighted. It's not always the positive result, right? We learn a lot from negative results.
Yep. Great.
Anything in RA? It won't be new, but I think the whole issue of cardiovascular disease around the JAK inhibitors has been the thorn in the side of all the rheumatologists. And I think we're going to have to come to some equilibrium that has yet to be determined who's safe to give these drugs to. And JAK inhibitors, does the anti-inflammatory effect outweigh if there is a prothrombotic effect? And they're separate and unrelated. When is the anti-inflammatory taking precedence over the thrombotic effect?
Yeah.
Still
a question to be determined.
I think we're going to see a lot more about combined drugs in lupus.
Okay.
Different pathways, approaching 2 different pathways. I think that's going to be around. I think we're going to see a lot more spatial transcriptomics, but we're not necessarily getting into the science. But there'll be maybe availability of biomarkers for the urine. Because it's been publicly announced that one of the companies that already brings us cell-based complement activation products and even hydroxychloroquine levels is very interested in urinary biomarkers. And if we had access to all these exciting things that we hear about in talks and could really apply it on a daily basis that insurance would accept, I think we'd be getting very much further. So I'm hoping we'll see sorts of things like that.
Yeah, and I think combinations of targeted therapies is on the horizon for RA as well. I mean, we're already seeing patients that are on a biologic for their RA and a biologic for their asthma or
that's
their
true.
atopy or something. And now there are these bispecific antibodies that are coming out that'll target 2 different cytokines. And so I think that that's really on the horizon. And our fear of using the 2 together needs to be revisited probably. And maybe it's not so bad.
I can't get away from this without talking about CAR T cells, right? Because every company in the world would kill me for not saying it.
Oh, yeah, CAR T.
But I think what's going to be interesting is, remember, we're putting so much on less than 2-year follow-up and very few patients.
Yep.
A year will go by, and that'll be another year to see whether these patients are truly drug-free.
Yep.
And I think we're holding our breath because this has probably been the biggest hype that I have seen in decades. And everybody's almost dropped what they're doing and moved to cell-based therapy. So we really need answers now because everyone is very excited. And a year can make a big difference in lupus, let me tell you. So, right?
Yeah, I agree. I have a patient who had RA and had CAR T cells
And
for
how'd it go?
for her lymphoma, and she's in complete remission.
Amazing.
No meds for a year
This,
now.
that's what I'm saying.
Yeah.
Everyone is really psyched, but we just need a little more time and to be a little patient.
So
Next year
that's
will
going to be
very telling.
that's going to be the big thing.
These people
of
are still in remission
Convergence
on no
24.
And
medications.
they don't have as severe of side effects. Their cytokine storm isn't as great.
40% people have such.
Yeah, but it's not as intense
Yeah,
in
right.
general. I mean, we only have a small number of
Yep.
people to know. But, when you have a big tumor load, you're killing
Yeah,
a lot
yeah,
of
yeah.
cells. But in the autoimmune diseases,
True.
it's not a big load of cells. And, and then the ICANS, is that what it's called? The neurological thing hasn't been very prominent.
Yeah, no, I haven't
And-
heard about that.
Yeah.
Yeah.
So
Great. Well, Joan and Jill, thank you so much
You're
for your
welcome.
time.
Thank
and
you,
thanks
John.
for giving us a
Now we're going to the
preview
rest
of what's
the
to
meeting
come.
so we can hear more about that.
it was fun.
It was fun.
All right.
Great.
Thank you
Thank
both.
you.
Take care. Well, there you have it. A preview of what's to come in rheumatoid arthritis and systemic lupus in 2024. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this episode at acronair.org, Apple Podcast, Spotify, and on your favorite podcast app. Until next time, it's never too late to start planning your trip to Convergence 2024 in DC. And of course, stay healthy.